We've got about an hour and a half total to talk about everything to do with acid-base. And so I'll spend about half the time on anion-gap metabolic acidosis, the other time on non-gap acidoses and alkaloses. We'll start with the real basics. So whenever I see a patient, whether it's clinically or on the boards, who has a potential acid-base disorder, the first thing I look at is the pH. So if it's lower than normal, the patient is acidemic, and if it's higher, it's alkalemia. And that tells us what the net effect of the one or more acid-base disorders that patient has, what the net effect is on pH. The next thing is to try and identify the underlying primary disorders. This, as you know, is the Henderson-Hasselbalch equation, which shows you how bicarbonate and PCO2 change in order to buffer acid in the blood. You do not need to remember the Henderson-Hasselbalch for the purposes of the boards. You won't be asked to calculate anything using it, but I think it helps you to remember what these disorders do to pH. So decrease in bicarbonate, as occurs in the metabolic acidosis, decreases pH, whereas the same decrease in PCO2, because it's in the denominator here, say a respiratory alkalosis, would have the opposite effect and raise your pH, causing alkalemia. So you're all familiar with these changes as causing these four primary disorders, which can occur individually or in combination. And it's a favorite of board examiners to give cases of patients that have mixed acid-base disturbance. So the next thing after we figured out at least one primary acid-base disorder is to try and figure out whether there is an appropriate compensatory response. And if so, to determine what the magnitude and direction of it is. And so all of you, I think, have seen tables like this, which show the magnitude of compensation expected in different disorders. You do not need to memorize this. The boards do not expect you to have this retained in memory, but you do need to understand what these tables mean so that when you're consulting them, when you're on rounds, you can figure out the expected compensation. And the important thing is the direction of the compensation. So for example, when you have a metabolic acidosis and your bicarbonate falls, you should expect to have increased ventilation in order to lower your PCO2 to attempt to compensate. So here it says for every 1 milliequivalent per liter drop in your bicarb, you would expect your PCO2 to drop by 1.2, and so on. So a couple of general points. The metabolic compensation for respiratory disorders is slow. So acutely, meaning within the first 48 hours or 72 hours or so, the degree of renal compensation may be quite small. Chronically, over the course of days to weeks, it's much greater. And that's why you have two different numbers for acute and chronic. And the other thing to mention is that the respiratory compensation for a metabolic alkalosis is variable and often incomplete. So here it gives the amount the PCO2 would rise in response to metabolic alkalosis. But as you can imagine, if you become very alkalotic, you're not going to stop breathing. There are other stimuli to respiration other than pH, namely your PO2. And I should mention that all of these slides that have a yellow background, they're sort of bonus slides, if you will, details that are useful for you to know, but not things that you need to memorize for the boards. And here's another one, just to show you that another way that you can address this is by using an acid-base map, such as the one that's shown here, where you seek out the appropriate position for your particular patient and figure out which of these disorders they have. Again, not something you need to memorize, but something that might be useful for you to carry in your pocket on your rounds. Okay, so the things that you do need for the boards are you need to remember which way the compensation is supposed to go, and you need to remember that compensation is never complete. What I mean by that is that let's supposing you have a metabolic acidosis and you're compensating by breathing down the PCO2, you can't return your pH completely to normal. You return it part of the way so that the acidemia is not as severe, but it doesn't return it to normal, because if it did, there would be no stimulus for the increased respiration, right? The other thing that I do remember in terms of compensation is Winter's formula, just because it comes up a lot clinically and it's easy to remember, and it's a pretty reliable formula, and this is specific for what the respiratory compensation would be in a metabolic acidosis. And in general, it's about 1.5 times the bicarbonate plus 8, and that's accurate to plus or minus 2. 1.5 times the bicarbonate plus 8. Which is pretty easy to memorize. Again, you don't need this sort of boards, but I've found that if you see questions on the boards and you use this, it sometimes gives you an extra clue that might be helpful. So here are some fairly simplistic examples. So here's a patient with a pH of 7.34 who's obviously acidemic. The PCO2 is elevated at 55, so that would suggest that this is a respiratory acidosis, and the bicarbonate is also elevated, and so we know that that's the expected metabolic compensation for a respiratory acidosis, and it doesn't return the pH all the way back to normal, so it's probably just a simple respiratory acidosis. Okay. Here's another example. This patient has a pH of 7.65, alkalemia. When we look at the PCO2, it is low at 30, so we're suspecting a respiratory alkalosis. But when we look at the bicarb, it's not compensating for respiratory alkalosis. In fact, the bicarbonate is also elevated, as you might see in a metabolic alkalosis. So the only way you could get this combination of features is if the patient had both a metabolic and a respiratory alkalosis. So this is a combined metabolic and respiratory alkalosis. And then here is a patient whose pH looks normal, but the patient clearly has an acid-base disturbance. The PCO2 is low, 22, which you might see in a primary respiratory alkalosis, and the bicarbonate is low, as you might see in a primary metabolic acidosis, but neither of those alone would give you the answer. So if you had a primary metabolic acidosis, yes, the PCO2 would be lowered, but it wouldn't be lowered so much that your pH was normal. So the only way the pH can be normal is if the patient has two acid-base disorders, both a primary metabolic acidosis and a primary respiratory alkalosis, and they're counterbalancing each other, and that's why the pH is normal. And one of the most common situations in which this occurs, as you're aware, is in salicylate poisoning. Okay, so if you have a metabolic acidosis, we usually calculate the anion-gap, which I will get to, and then if they have an anion-gap acidosis, we often calculate something called the delta-delta, which I will also get to in a little later, and that often also gives us a clue as to whether there's a mixed disorder. Okay, so moving straight on ahead to metabolic acidosis. When we see a patient with metabolic acidosis, often the first thing you want to do is to figure out whether they have an anion-gap or non-gap acidosis. So the serum anion-gap is the serum sodium minus the sum of the chloride and the bicarbonate. And this is equivalent to all the other unmeasured anions in the blood minus all the other unmeasured cations. And the reason that works is because there has to be electrode neutrality, right? The number of positively charged and negatively charged ions in the blood is always equal. So this gives us an estimate of the excess of unmeasured anions to unmeasured cations in the blood. Normal range, 8 to 12 milliequivalents per liter. So what are these unmeasured ions? So these are the unmeasured anions, and these are the unmeasured cations. Probably a major component of this is albumin. So the major assumption here is that this balance of unmeasured anions and cations is pretty constant. Yes, potassium does vary, but it varies over a range of 2 or 3 milliequivalents per liter. Not a big change. Calcium and magnesium over very small ranges. Same for all of these. The serum anion gap is about the same in everyone, unless something else happens. Now, since the albumin plays such an important role in the anion gap, if you have severe hypoalbuminemia, the anion gap can also change. Essentially, since there are negative charges on the albumin, if your albumin concentration is low, the anion gap should be low. And so to correct for that, when we're trying to look for other unmeasured anions, we usually add to the anion gap for the fall in albumin. And the rough rule of thumb is to add 2.5 to the anion gap for every 1 gram per deciliter that the albumin is below 4. So if you have a patient whose albumin is 2, you add 5 to the anion gap. Okay, so what is this anion gap and how does it work? So to give an example, consider a patient who's developed lactic acidosis, which is the quintessential anion gap acidosis. So what's lactic acid? Lactic acid is hydrogen ions, so that's the acid part, and lactate anions. And so if that's entered into the blood, the acid part gets buffered by the bicarbonate in the blood and turned into CO2 and water. So now you've got sodium in the blood and lactate anions. So the bicarb in the blood is decreased, and in its stead, you have a different anion, which is lactate. But now this is an unmeasured anion. We don't measure it. So if the anion gap is the sodium minus the chloride plus bicarb, if the bicarb goes down and everything stays the same, then the anion gap has to go up, right? If the bicarb goes down by 5, your anion gap goes up by 5. And really what this is measuring is it's a surrogate indicator of an unmeasured anion. So that 5 is actually 5 milliequivalents per liter of lactate that's appeared in the blood now. And lactate is a very good example because in many labs, for example in our lab, we measure lactate in milliequivalents per liter. So if your lactate goes up by 5 milliequivalents per liter, your anion gap should go up by 5. And that's quite useful to know. Okay, so what causes a high anion gap metabolic acidosis? Everyone knows mud piles or some version of that mnemonic, where M is methanol, U is uremia or renal failure, D is diabetic ketoacidosis, P is paraldehyde, which we don't use anymore, I would be iron or isoniazid, L lactic acidosis, E is ethylene glycol, but also ethanol and alcoholic ketoacidosis, and S is salicylates. There are a number of things that are worth remembering that aren't necessarily in this mnemonic. So rhabdomyolysis can cause release of intracellular acids, not entirely clear exactly which ones, but occasional patients can have a quite severe high anion gap metabolic acidosis. Toluene abuse causes, in some cases, an anion gap metabolic acidosis, in other cases, a non-gap, and I think we have a case of that later that we can talk about. And in addition to the conventional forms of lactic acidosis due to decreased tissue perfusion, like in patients in shock and sepsis, which we call type A lactic acidosis, there are also patients who have lactic acidosis that's not associated with tissue hypoperfusion, which we call type B lactic acidosis. And some of the most common types that we encounter nowadays are from meds like metformin, some of the antiretroviral drugs, and linezolid. In addition, all of the endogenous lactic acid, like all of our endogenous amino acids in our body, are of the L optical isomer, but you can also get lactic acid generated in the gut, which is D-lactate, and that's called D-lactic acidosis, which we'll go into. And that's important to recognize because when you send the lactic acid to the lab, it does not measure this. And then a couple of others to remember, propylene glycol and pyroglutamic acidosis, which is also called 5-oxoprolinuria. Okay, so in some cases, it's pretty obvious why these cause high anion gap acidosis, for example, ethylene for example, lactic acidosis. In many of these other cases, it's not at all obvious because they're not actually acids. And the reason that they cause an anion-gap acidosis is in some cases because they're metabolized to acids or that they stimulate acid generation in the body. So methanol is metabolized to formate, ethylene glycol to oxalate, propylene glycol to lactate, toluene to hyperate. In ketoacidosis, the acids are acetoacetate and beta-hydroxybutyrate. And in uremia, the acids that are being retained are the acids of things that are ingested in our diet, particularly from proteins, so sulfuric acid and phosphoric acid from proteins, and uric acid. And the failure to excrete those causes the anion-gap part of the anion-gap acidosis. Okay, so if you see a patient that has an anion-gap acidosis, it's often helpful to ask the question, is the increase in anion-gap appropriate for the degree of metabolic acidosis? And this helps, again, provide some clues as to whether there's a mixed acid-base disorder. So this is recommended on most standard curriculums and may be on the boards, although it's sort of on the cusp of what's considered the right level for the boards. But I think clinically it's quite useful. And so here's the premise of the delta-delta, which is that for every 1 milliequivalent per liter of acid that enters the circulation, it lowers your bicarb by 1, or in other words, it should increase your anion-gap by 1. So therefore, if you calculate the delta anion-gap, the change in your anion-gap from normal, and the delta bicarb, the change in the bicarb from normal, they should be equal, and it should be equal to 1 if it's a simple anion-gap metabolic acidosis. So how do we calculate this? So if you assume a normal anion-gap is 10, you subtract 10 from the actual anion-gap in the patient. If you assume a normal bicarb is about 24, you take the bicarb of the actual patient away from 24, and that gives you the delta anion-gap and the delta bicarb, and you simply calculate the ratio between them. And it should be 1 if it's simple anion-gap acidosis. If it's lower than 1, what that's saying is that there's quite a severe acidosis, but the anion-gap didn't really increase very much. And so one possible example is if there's also another process causing an acidosis that doesn't raise your anion-gap. In other words, a superimposed non-gap acidosis. Okay? On the other hand, if your delta-delta is greater than 1, what that's saying is that there's a very high anion-gap, but the acidosis doesn't really seem as severe as you would expect. And one reason for that would be if there's a superimposed metabolic alkalosis. So the metabolic acidosis and alkalosis tend to cancel each other out, so the bicarb is nearer to normal, but the high anion-gap remains, and that's the clue that there's an underlying severe anion-gap acidosis that may not be obvious. Okay? So here's an example of how that might be used. So here's a 21-year-old male who's intoxicated with ethanol and presents with a history of repeated vomiting, and he's obtunded. So you can see here are the lights, and here's the acid-base disturbance. And the question is, what's the nature of the acid-base disturbance? So the bicarb is low and the pH is low, so it looks like a primary metabolic acidosis. The PCO2 is, let's see, a little bit elevated, so that's not what you would expect with a simple metabolic acidosis, so it's probably a little bit of a respiratory acidosis. And then if we focus on the metabolic acidosis, the anion-gap is 136 minus the sum of 90 and 18, 108, so that gives you 28. So the anion-gap is 28, which is clearly elevated. And then to calculate the delta-delta, we take 28 from 10, so that's the delta anion-gap is 18. And for the delta bicarb in this patient, we take 18, his actual bicarb, from 24, normal bicarb, and that leaves 6. So the delta-delta is 18 divided by 6, which is 3. In other words, the anion gap is 3 times higher than you would expect based on the lowering of the bicarb. The other way of doing it that some people like to do is to take the delta anion gap, 18, and add it to the bicarb. And if that returns it to normal, that would have the same connotation as the delta being 1. In this case, when we add the 18 to the bicarb of 18, we get 36, which is high. So what this is suggesting is that this patient must have an underlying metabolic alkalosis as well. Okay, so on to the more subtle version of this. So that's what I've showed you is the sanitized version that you have to remember for the boards. As you know, reality is always a little more complicated. So in this case, it turns out that the normal delta-delta in a simple anion-gap acidosis is not really 1. Often it's higher than 1. Why is this? Because the delta-delta assumes that all of the bicarb is buffered by, so all of the acid is buffered by bicarb in the blood, but it really isn't. A lot of the acid actually enters the cells and is buffered inside the cell. In fact, the more severe the acidosis, the more of that acid has to be buffered intracellularly. You can imagine someone who has a bicarb of, say, 5, and they receive more acid load. The bicarb can't get much lower than that. So what does all that acid do? It actually goes inside the cell. So the average delta-delta of a simple lactic acidosis is actually closer to 2. It's around 1.6 in experimental studies. The other thing that you have to be aware of is that acid anions don't just stick around in the blood and cause this anion gap. A lot of them are small anions that get excreted in the urine. So as you excrete that, the anion gap can drop. So a classic example is diabetic ketoacidosis. If you catch those patients early, they can have a delta-delta that's close to 2, which is actually consistent with a simple DKA. As you catch them later, they excrete their keto anions, and the delta-delta can get less and less until eventually it's close to 0, looking like a non-gap acidosis. So a more practical way of using the delta-delta might be to consider metabolic alkalosis when the delta-delta is a little higher, maybe greater than 2. If it's between 1 and 2, it's a little fuzzy. And if it's less than 1, it could be a superimposed metabolic acidosis, but it could simply be that your anion is being excreted in the urine. Okay, so back to the main curriculum. So when you have a patient with anion-gap acidosis, particularly if they come in from the outside in the emergency room, and you suspect or it's possible that they could have an intoxication, we always check the serum osmolality to determine the serum osmolar gap, and that turns out to be a very good clue to some of these intoxications. So what's the osmolar gap? So it's the difference between the measured serum osmolality and that which we can calculate just based on the most important components in the serum. So the most important components of osmolality in the serum are the serum sodium and its accompanying anions. That's why we multiply it by 2. Glucose, which we divide by 18 because the glucose is in mg per deciliter and the molecular weight of glucose is 180. And the BUN, which we divide by 2.8 because there are 2 nitrogens in urea which have a molecular weight of 28. And so just for your information, but not something to memorize, but something that I found clinically quite useful is that, so let's back up a little. So when there's a big difference between the serum osmolality that you measure in the lab and the one that you calculate from this, it must mean that there are other things that are making a significant contribution to the osmolality that you don't have in this formula. And some of the things that we know of are alcohols, things like ethanol, ethylene glycol, methanol, and so on. And so when you calculate this osmolar gap, clinically, it's sometimes useful to know how much of that is contributed by a certain substance. So for example, if you have a patient that comes in intoxicated and they have a blood alcohol level of a certain amount, let's say 46, you want to know how much of that osmolar gap is contributed by an ethanol level of 46. And the answer is you take its concentration in mg per deciliter and divide by 4.6, and that's 10. So if your serum osmolar gap is 10, you can say it's all from ethanol. If it's 20 or 30, then you can say there must be something else. And basically, for all of these substances or any new thing that you suspect that you're measuring mg per deciliter, if you divide it by 1/10 of the molecular weight, that gives you the number of milliosms per kilogram that they contribute. So the molecular weight of ethanol is 46, ethylene glycol is 62, and so on. So back to what we do with this. So our normal osmolar gap, quote unquote, is less than 10. So if it's greater than 10, it suggests other osmotically active substances, which are usually these alcohols. Okay? Ethanol, ethylene glycol, propylene glycol, and methanol all can cause both a high osmolar gap and an anion-gap acidosis. By contrast, isopropanol causes an osmolar gap, so it's also a small alcohol, but it's not metabolized to an acid. So that's the exception. This is the one that doesn't cause an anion-gap acidosis. So if you see a case of this where the anion gap, there's no acid-base disturbance, but just an osmolar gap, you would suspect isopropanol. And just for completeness, salicylates don't change the osmolar gap, but they do cause an anion-gap acidosis. Okay, so in the last few minutes here, I'm going to go over some of these syndromes of anion-gap acidosis, because these are things that are worthwhile recognizing, and they always come up in the boards. And some of these are intoxications, and I know you have an intoxication lecture later on in the week, so you'll be hearing a little bit more about this. But as an acid-base problem, these are really common and need to be recognized. So the first is ethylene glycol poisoning, very common in this part of the world. Patients that are present with this can appear inebriated, so they appear drunk, but they don't have the smell of alcohol in their breath. And this is in contradistinction to ethanol or methanol, which actually smell alcoholic. Ethylene glycol is odorless. They can have a number of multi-system manifestations, including heart failure, an ARDS picture, and it can cause renal failure and ATN. Unlike methanol, which is a very closely related problem, in ethylene glycol poisoning isn't toxic to the retina, so you don't get any eye changes. They have, as I mentioned, both an anion and osmolar gap acidosis. Oftentimes lactate is up a tiny bit, but don't be fooled by that. And this is where knowing that a milliequivalent per liter of lactate contributes a milliequivalent per liter to the anion gap helps you determine someone has a little increase in lactate. That's not the explanation for a big anion gap acidosis. Because the ethylene glycol is metabolized to oxalate and chelates calcium, these patients can sometimes be hypocalcemic, and they can often have calcium oxalate crystals in the urine. So dihydrate crystals look envelope-shaped like this. Monohydrate crystals look needle-shaped, and these crystals in turn can cause microscopic hematuria. And then finally, because one of the most common causes of ethylene glycol poisoning is from coolant in car engine coolant, and that often has fluorescein, a fluorescent dye, added to it for diagnosing leaks in engines. It's said that the urine can fluoresce when patients have ethylene glycol poisoning. So if you look at it in the dark with a UV lamp, a so-called Woods lamp, you can sometimes see that. Now, these are neither sensitive nor specific, but they're sometimes helpful. Okay. So just to explain how this all works, so ethylene glycol is itself the alcohol, so it contributes to the osmolar gap. But the key here is that it's metabolized to these acids, which are very toxic. And the enzyme that metabolizes it, it's alcohol dehydrogenase, same enzyme that metabolizes the alcohol that some of you may have drunk last night if you were up late partying. And of these, the most toxic is glycolic acid. And now glyoxylic acid can also be metabolized to glycine and alpha-hydroxy beta ketoadipate. And the cofactors for this are pyridoxine and thiamine. So we often give pyridoxine and thiamine to patients with ethylene glycol poisoning, but these are not, I repeat, not the major pathways. So the mainstay of treatment for ethylene glycol is to try and prevent it turning into these toxic acids. And so you want to try and inhibit alcohol dehydrogenase. In the old days, we would compete for it with ethanol. So you can give patients an ethanol drip, and when they go on dialysis, you either turn up the drip. If they need dialysis, you can turn up the drip, or actually some people have added ethanol to the dialysate. But nowadays, many countries now we use fomepizole, which is a specific drug that's highly potent and inhibits alcohol dehydrogenase. This is just to remind you, not something that you will, I think, come up on the boards, but the osmolar gap goes down as the anion gap goes up. So ethylene glycol contributes to this large osmolar gap, and over time, as this gets metabolized, the anion-gap acidosis gets more severe, while ethylene glycol tends to disappear. So it's theoretically possible to catch patients when they have a high osmolar gap, but very little or no anion-gap acidosis if it's early on. And conversely, late in the disease, it's theoretically possible to see patients that have a high anion-gap acidosis, but very little or no osmolar gap. Again, not something you'll see on the boards, but a useful clinical pearl. In terms of management, GI decontamination is always done, but probably not terribly helpful in ethylene glycol poisoning. Sodium bicarb is useful, both because it corrects the metabolic acidosis and also because it alkalizes the urine and traps these acids like glycolic and glyoxylic acid. But as I said, the mainstay is to give an alcohol dehydrogenase inhibitor. We generally don't treat asymptomatic hypocalcemia because raising the calcium would further precipitate calcium oxalate in places we don't want it. And then hemodialysis is extremely effective at treating ethylene glycol poisoning. So the indications for giving fomepizole or ethanol are shown here. Generally, one should have a low threshold. Oftentimes, we have patients who have an osmolar and anion-gap acidosis. We send the ethylene glycol level, but it hasn't come back. You should not wait for that to come back. If you have a reasonable clinical suspicion, you really need to start the fomepizole immediately. And then in terms of hemodialysis, there are some well-recognized indications. Clearly, if patients have acute kidney injury, not only to treat the uremia, but also because they're unable to excrete either the ethylene glycol or the acids, and so you'd need to do dialysis. Obviously, if acidemia is refractory or getting worse, or if they have end organ damage, barring all of these, if you want an actual level at which you should dialyze, many authorities think an ethylene glycol level of 50 or an elevated osmolar gap of greater than 10 should get dialyzed. Methanol intoxication metabolically behaves very similarly, but these patients do have an alcoholic fetor. They have retinal damage, so they can present with blindness, dilated pupils, retinal and optic disc edema. They, again, just like ethylene glycol, have an anion and osmolar gap, and they do not have the calcium crystals. Some of the other features that you sometimes see in methanol intoxication: myoglobinuria, abdominal pain, and occasionally acute pancreatitis. And the treatments is essentially the same. You've got to give them fomepizole or ethanol and consider hemodialysis. There are a couple of unique aspects to methanol poisoning. Generally, the acidemia has to be treated more aggressively because it's considered that formic acid is more toxic than the alkalinized formate. Folic acid is a useful cofactor for metabolism of formic acid. And for some reason that's not well understood, they're at risk of intracerebral hemorrhage. So if you dialyze them, it's recommended to avoid heparin. Salicylate intoxication can present with a multitude of different symptoms and signs. So it's often challenging to make the diagnosis. What I've highlighted in orange are the features that I think are most characteristic and useful in trying to make the diagnosis. And if you have a case on the boards, they'll almost certainly give you some of these clues. Things like tinnitus, not many things cause that, or deafness. High values of order vital signs, so they're febrile, they hyperventilate, and they're tachycardic. And then they always have some sort of acid-base disturbance. By far the most common in adults is a combination of respiratory alkalosis and metabolic acidosis, but they can even have triple acid-base disturbances. And the metabolic acidosis is thought to be because the salicylate causes the endogenous generation of lactase and ketoacids. The management, we're not going to have time to talk in great detail about it, but some of the things that are important to remember is to have a high threshold, in this case for intubating patients who are hyperventilating and appear to be in respiratory fatigue. And the reason is that oftentimes when you intubate and ventilate patients, if you don't increase the minute ventilation enough, they become less alkalemic, or I should say more acidemic. And that's important because the more acidic your blood is, the more of your salicylate is in the form of salicylic acid, the uncharged form, which enters the CNS very easily and has a lot of toxicity. So one of the goals of salicylate intoxication is to actually alkalinize the blood. The second goal is to alkalinize the urine, because that actually traps the salicylate in the urine and helps excretion. And so alkaline diuresis is one of the treatments for salicylate intoxication. So the goal is to try and get the urine pH to 7.5 if you can, and get the arterial pH a little bit up, but so not as high as keep it below 7.6. So you can't alkalinize the urine with acetazolamide, because even though that will alkalinize the urine, you would actually acidify the blood. Okay. I think I'll skip these pictures, which basically say what I just mentioned. Okay, so now we're all frozen. Okay, alcoholic ketoacidosis. So this often, like all ketoacidoses, presents with nonspecific symptoms: abdominal pain, abdominal tenderness, nausea, vomiting. Unlike diabetic ketoacidosis, the glucose would be normal. The predominant ketone that's generated is beta-hydroxybutyrate. So it's a classic finding is beta-hydroxybutyrate may be positive, but acetoacetate or acetone might be negative or borderline. This often occurs after patients have had a large binge and then stopped for a few days. And so serum ethanol levels are often normal in these patients, undetectable, but sometimes they're present. There's always a contribution of lactic acidosis, but it's a relatively minor contribution. And the treatment, as you all know, is just to give IV dextrose-containing fluids. A brief mention about type B lactic acidosis. There are certain reverse transcriptase inhibitors that classically are toxic to the mitochondria in the liver and cause sometimes a very severe type B lactic acidosis. Fortunately, this is rare now because we don't generally use these drugs very much, didanosine and stavudine, but it's important to be aware of this because it has a very high mortality. D-lactic acidosis, as I mentioned before, is generated by bacterial overgrowth in the gut, primarily in the colon, and it occurs because carbohydrates that are ingested take a short track and go into the colon. And so that occurs in patients that have some sort of short bowel syndrome. And they present with neurologic symptoms, so they have change in altered mental status, and when they come into hospital, they will be seen to have an anion-gap acidosis, but a conventional lab draw for lactate would appear to be negative, but if you sent it for D-lactate, or even send a urine for D-lactate, it would be positive. And because this requires carbohydrate intake, if you bring them in and make them NPO and give them just IV fluids, this actually resolves spontaneously. So not the scourge of the modern world, but something that can be perplexing if you're not aware of it. This is to remind me to talk briefly about propylene glycol, which is used as the vehicle in IV drugs. And by far the biggest offender is lorazepam or Ativan. Ativan drips have a lot of propylene glycol, and the propylene glycol is actually metabolized to lactic acid. So these patients can present with a lactic acidosis if they're getting very, very high drip rates of lorazepam, as occasionally happens to patients that are in the ICU. Finally, just to mention pyroglutamic acidemia, also called 5-oxoprolenemia. Again, not a major cause of morbidity and mortality, but something that can cause puzzling anion-gap acidoses in the ICU, and being aware of it helps you to sort through it and distinguish it from more serious disorders. So this often occurs in patients who are critically ill and septic. Often these patients are being treated particularly of acetaminophen and present with an unexplained anion-gap acidosis. What this is showing here is the metabolism of glutathione, which you all know is a metabolite that we use intracellularly as a reducing metabolite that basically mops up oxidative stress. And it's generated from the amino acids glutamate and cysteine by this enzyme gamma-glutamyl cysteine synthetase. But glutathione feeds back negatively to inhibit this enzyme. When glutathione is consumed, which occurs when you treat patients with acetaminophen or in patients who are septic or have SIRS, this negative feedback is released and more glutamate and cysteine enters this pathway and accumulates as this intermediate gamma-glutamyl cysteine. And the only way the body knows to get rid of this is to change it to pyroglutamic acid or 5-oxoproline. So these can be detected in the blood and the urine in patients with this disorder. And here's some suggested reading on anion-gap acidoses.